The Finding Cancer Early tool from the Cancer Council of Australia is a useful guideline for GPs to evaluate symptoms that they are confronted with and figure out how likely it is those symptoms are reflective of underlying prostate cancer. The resource is an evidence-based tool which uses the statistical aspect called positive predictive value, which, recall, is the proportion of the times that the patient has disease divided by the number of times you thought they had the disease. So more specifically, true positives divided by true positives and false positives. So using this tool, any positive predictive value over 2% is suggested for further evaluation, and any positive predictive value of more than 5%, referral is recommended. So moving on then to the goal here, which is saving lives and saving quality of life, and that's a common thread for all of us practicing in medicine and surgery. At first glance, the concept of finding prostate cancer early may seem a little bit controversial to some members of the community, even to some members of the medical community. Certainly as a urologist, we're hearing over and over again, prostate cancer, men die with it, not of it. Well, the truth, unfortunately, is very different, and 1 in 30 Australian men die of prostate cancer. And in fact, as you know, it's the second most common cause of cancer death. 1 Australian man is dying of prostate cancer at least every 3 hours, every day of the week, every week of the year. A highly lethal, highly significant prostate tumour for our community. The other myth we hear frequently is that prostate cancer is the old man's disease. In fact, prostate cancer incidence increases rapidly over the age of 50. And in fact, 1 in 3 men are diagnosed with prostate cancer before the age of 65. So indeed, prostate cancer is an important target for finding cancer early and improving outcomes for the patients in our community. So what's been happening with prostate cancer over time? So if you look at the graph on the left, that's the incidence of prostate cancer in the solid blue line, and below it, the black line, is the mortality from prostate cancer. And you can look over time. The interesting thing that's happening recently is shown in the dots. And you can see that the incidence of prostate cancer has fallen. Why is that? Well, one potential explanation is that there is reduced PSA screening going on. And then you look at the mortality and say, well, look, the PSA screening is going down, perhaps the incidence is going down, but look, nothing's happening to mortality. The problem is shown on the right graph. On the right graph, you have the incidence of prostate cancer in the blue line, and the black line shows the mortality. And what you can see is the difference between the two curves is about 15 years. So any change we make today in PSA screening and reduced detection of prostate cancer is not going to have any effect on mortality now, but it will do in 15 years' time. I think this is one of the concerning trends. So when we're trying to detect prostate cancer early, it's important to be aware of the risk factors for prostate cancer. We've already touched on one of those, age. And certainly the incidence of prostate cancer increases with increasing age. However, genetics are equally important. Now, the genetics of prostate cancer is still being discovered and elucidated. There are numerous genes which have been linked to prostate cancer, including BRCA1 and 2, HOXB13 and DNA mismatch genes. Those particular genetic tests have yet to reach sufficient maturity to enter clinical practice. But on history, we can find features which may tell us this patient has an increased risk genetically for prostate cancer. And in particular, if the family involved has a history of breast, ovarian or pancreatic cancer, we know that that may cluster with prostate cancer risk. Also, if a patient has multiple, particularly first-degree family members who have been affected by prostate cancer, their risk more than doubles over background, even if, especially, the relatives who have been affected were diagnosed in their younger years, that is to say, less than the age of 55. So an awareness of those risk factors is important. Let's look at the tool. So the tool, as discussed, uses single clinical features or pairings of clinical features to try and predict the likelihood that that patient has underlying prostate cancer. If you look across, firstly, consider lower urinary tract symptoms. So they're shown across the top, such as nocturia, hesitancy, frequency and urgency. So as a GP, you'll be seeing patients on a daily basis with lower urinary tract symptoms. So those are broadly classified as storage or voiding. Storage voiding symptoms are those due to the bladder, really. So that's frequency, urgency, nocturia. And the voiding symptoms are the ones due to the outlet of the bladder. So that's hesitancy, poor stream, interrupted stream, straining to void, and so on. So lower urinary tract symptoms in general really just reflect bladder pathology or bladder outflow pathology or a combination of the two. They're not really specifically linked to prostate cancer, and the tool shows that. So if you look at the symptoms, nocturia, positive predictive value 2.2%, hesitancy 3.0, frequency 2.2, urgency 2.2. So those individual symptoms really are not predictive of prostate cancer. Look at some other single clinical features. Let's look at hematuria. Hematuria, again, only weakly predictive of prostate cancer. That's not to say that hematuria is an insignificant feature. It is a highly significant feature. It's just not that relevant to prostate cancer, and we'll come back to that. Similarly, weight loss as a single feature, not that relevant to prostate cancer, but a highly significant feature for other reasons. But let's look at a rectal exam, a malignant rectal exam. You can see that here. The predictive value of a malignant rectal exam is 12%. That's a bit concerning. Now, a clinical exam of the prostate is, from an experienced GP, is a hugely valuable tool. And I think most GPs would feel comfortable in discriminating between a smooth, benign feeling, soft feeling prostate and a prostate that feels firm, irregular or even nodular. And that particular finding is enough for us to be really concerned this patient may well have underlying prostate cancer that requires further evaluation. And you can see the significance of that in the tool. When you combine malignant rectal exam with nocturia, positive predictive value 15%, hesitancy and a rectal exam that's malignant 10%, nocturia, and weight loss 12%. So the other real red flag that sways outcomes in this tool is weight loss. And as we saw before, weight loss as a single measure is not predictive, but combine it with, for example, nocturia or a malignant exam, it's highly significant. So as a GP, when you're evaluating these patients who are coming in with symptoms of the lower urinary tract, a clinical exam to examine the prostate to work out whether it feels malignant or not, some direct questioning relating to nocturia, weight loss, and so on, hugely important. And of course, hematuria important, but for other reasons. It stopped moving. It's not advancing. There we go. Sorry about that. Slight technical issue. All right. So when we look at this particular tool, there are a couple of limitations. So first of all, the severity of the patient's symptoms is not proportional to their risk. So if they've got severe nocturia, doesn't mean they've got a very high chance of prostate cancer. That's just a symptom by itself. Also, remember, this is a tool. So it doesn't replace your expertise, experience, training, or your judgment. It really is just a tool that you can use and that can help you. We spoke briefly about weight loss, and we explained that as a single clinical feature, it's not particularly predictive of prostate cancer, but as an entity, of course, it's highly significant. Unexplained weight loss needs urgent investigation for other reasons. Hematuria also. So hematuria is not significant in terms of a single symptom in predicting prostate cancer, and that's because it's really more significant as an entity for the bladder. Hematuria comes in two forms, as you know, macro and micro. So macro hematuria is visible hematuria. Micro is the hematuria we detect on a dipstick or on a microscopy. Both are significant and require evaluation. One option there is to send the patient to a one-stop hematuria clinic, such as we run through the Fiona Stanley Hospital. And in this particular service, patients can have all the investigations they need, a consultant review and a cystoscopy all in the one setting. Hematuria really can't be dismissed unless there is a clear proven urinary tract infection and the hematuria resolves after the urinary tract infection has been treated. Another limitation we need to think about is the digital rectal exam. We discussed that before and how an experienced GP's finger is very useful in discriminating malignancy versus a benign exam. It is a useful sign. Why is it controversial? Well, the current Cancer Council Australia PCFA guidelines for PSA screening have not chosen to incorporate a rectal exam, and we'll come back to that towards the end of tonight's webinar. But basically we can see here that digital rectal exam is a valuable tool, a positive predictive value of 12% in primary care. Also, for example, a malignant exam may be sufficient to make a clinical diagnosis of prostate cancer, particularly in an elderly and infirm patient, without subjecting them to any other tests. Okay, so you've used the Finding Cancer Early tool. We've recognised that the threshold for urgent evaluation is about 5%, referral is 5%. We've used the rectal exam, it's helped us. When do we refer the patient? Well, we refer the patient if the rectal exam is concerning or if the PSA is concerning. So if the PSA is above a threshold of 3.0 and the repeated measurement is also over 3.0, or the patient's PSA is above the 95th centile for age, or we are concerned about the PSA kinetics, then we should refer the patient for further evaluation by a urologist. And so what we've talked about here is the Finding Cancer Early tool. And we've decided that if the patient has a positive predictive value of more than 5%, they should be referred. In this situation, we're using PSA. And PSA is a good test when there are symptoms to help identify patients who have underlying prostate cancer. And anyone who has symptoms should be investigated to find out whether the cause of their symptoms is prostate cancer. Let's move on now to a brief discussion of the current PCFA guidelines and Cancer Council of Australia guidelines for PSA testing in asymptomatic men. This really is a topic by itself, so we won't spend too much time on this. So the Cancer Council of Australia and the Prostate Cancer Foundation of Australia last year assembled a panel of experts which included general practitioners, public health physicians, oncologists, urologists and so on. And they evaluated the world literature to date on the efficacy and appropriateness of PSA screening in asymptomatic men. As a result of that panel, a consensus statement was released last year, which was ratified in, I think, around May by the Royal Australian College of General Practitioners. Let's just go through some of the facets of that consensus statement and see how it relates to PSA screening in asymptomatic men. The first statement is that we should discuss the benefits and harms of PSA screening before we undertake it. So the days of putting PSA on a panel of labs probably need to go, but rather PSA screening should be done when the patient is keen on it being done. So when we're thinking about the benefits and harms of PSA screening, what are they? Well, firstly, the harms. There's about a 20 to 40% chance that if a patient has PSA screening, they will end up having diagnosed indolent disease that may never end up needing treatment. And of course, that may lead to a number of unnecessary investigations, of course, anxieties and so on. To temper that particular concern, I would suggest that most urologists today practice in an MDT context. So when diagnosis happens, whether treatment happens is a considered decision based on the biology of that patient's cancer and that patient. So therefore, the impact of overdiagnosis is a little bit lessened by the MDT process. In addition to that, some of the harm that comes out of overdiagnosis is really to do with repeated prostate biopsy. And I think with time we're getting better at stratifying patients' risk for their prostate cancers, and also we're integrating MRI. And MRI, of course, is a very non-invasive way of keeping track of the prostate gland to work out whether upgrading is happening over time, as opposed to repeated biopsy. So that is a concern, but we have a workaround. Also, another potential harm is the adverse effects of treatment. And certainly, short of active surveillance, every treatment we do for prostate cancer has the potential to affect a patient's quality of life. Things like urinary control, potency, and so on. And those things do need to be considered. But again, I think if treatment happens in centres of excellence, where there's high volume, where there's MDT input, where there's expertise in the particular treatments, then the adverse effects of treatment can be lessened, and we can see better results for urinary control, better results for potency, better cancer cure rates. The other issue, of course, is the benefit of PSA screening, and this is possibly underplayed. Certainly, there is level 1 evidence that PSA screening in the correct patients improves survival, and the number needed to treat is about 12, which compares comparably to, for example, breast cancer screening. The second consensus statement: the harm may outweigh the benefit in men aged over 70. This really speaks to the concept that the prostate cancer biology is a long-term game. So for a patient to realise a benefit in prostate cancer treatment, they've got to live a long time, probably 7 to 10 years minimum. So if you've got an elderly, frail patient, they're unlikely to have a significant effect from prostate cancer in the remainder years. So that is the basis of that statement. But I would suggest to you that if you have a man who is over the age of 70 but well, he may well have years and years left to run, and therefore they may just benefit from PSA screening, because at the end of the day, it's a patient's biological age, not their chronological age, that is so important. If PSA testing is to be done, a suggested time interval is every 2nd year, and beginning at age 50, stopping at age 69. But you may consider testing in younger patients if they are intermediate or high risk of prostate cancer. And we talked about why the sorts of patients that may be at high risk of prostate cancer earlier. And as discussed, digital rectal exam, when it comes to PSA screening and prostate cancer screening in the asymptomatic man, is no longer considered necessary in primary care. And that is because for every prostate cancer that is picked up by the abnormal rectal exam, 2 false positives are picked up. Again, one's individual experience can sometimes affect this. And certainly I have diagnosed and treated many men who have had an abnormal rectal exam but no other features to suggest prostate cancer, because the appropriate referral was made. You will also notice that in the new guidelines, the PSA threshold is now 3.0. which is a little lower than previous. When you look at a threshold of 3.0, we have to remember that this is purely a line drawn in the sand. If you lower the PSA threshold lower and lower and lower, you're going to pick up more disease. There's going to be better detection, but it's going to come at the cost of false positives. When the American Cancer Society did their review on PSA thresholds, they reported that if you use a PSA of 4.0, which was the traditional level, the sensitivity for high-grade prostate cancer, that is Gleason grade 8 and above, was only 50%. So half the patients with highly significant lethal prostate cancer weren't getting picked up with a PSA level set at 4. If you lower the level to 3, it does cost a bit of specificity. It falls from 91 to 85, but it improves the sensitivity. And in particular, it improves the sensitivity of those patients with the most aggressive, most highly relevant prostate cancers. And I think this again is the reason why the threshold has been lowered. So really just to look at those recommendations. If you have an asymptomatic man and there is concern about potential for prostate cancer, and that patient is interested in prostate cancer intervention in the interests of their health long term, then their family doctor can discuss with them the potential harms and benefits of PSA testing and undertake PSA testing along the lines of the consensus. Further information about PSA screening is also found in the RACGP Red Book and online through the Cancer Council of Australia. So to summarise here, a high PSA in the presence of lower tract symptoms and even a benign feeling prostate, that patient can still have prostate cancer and should be referred. A concerning rapid rise in PSA, regardless of symptoms, needs to be repeated and potentially further evaluation. And we can see the importance of a digital rectal exam and PSA in men over the age of 40 with lower urinary tract symptoms. Okay, so you've identified a patient who may well have prostate cancer. You're concerned. What should you do? Referral. So the criteria for referral, for example, that we use at the Fiona Stanley Hospital is if the patient has an abnormal rectal exam, irrespective of the positive predictive value, irrespective of their PSA, please refer for evaluation. If the PSA is more than 3, if the kinetics are worrying, please refer for evaluation. If you're concerned, please refer. Just to speak briefly about the One Stop Prostate Clinic. The One Stop Prostate Clinic has been set up at the Fiona Stanley Hospital and interestingly is now coming up for the Health Excellence Awards in a few weeks' time. It's coordinated by a specialist prostate cancer nurse. Referrals come in. Any remaining investigations that are required are organised. If an MRI is needed, it's done same day. The patient sees the consultant with the results of the MRI and has a biopsy all in the one trip. And that service is available to all Western Australian patients, but it's of particular relevance, I think, to our regional patients, where multiple trips to clinic, imaging, biopsy, review, etc. can be saved, and it is a very, very efficient way of that patient getting the care they need. If you've got any queries or need any more information, you can contact the One Stop Prostate Clinic. So let's just go through a couple of cases and then we'll be some time for questions if you're interested. So let's talk about case number 1. So Chris is a 64-year-old man. He comes to see you with lower tract symptoms, as many patients do. He's got nocturia and urgency. So what's your differential diagnosis? Well, nocturia and urgency are storage lower urinary tract symptoms. So they may represent a bladder pathology or a bladder outflow obstruction with secondary bladder overactivity. Bladder pathologies include urinary tract infection, stones, and even TCC. And the outflow symptoms with things like BPH, strictures, and so on. So what's your approach? Coming back to our tool, we know that nocturia or urgency as singular entities are weakly predictive of prostate cancer. Again, when they are combined, weakly predictive of prostate cancer, positive predictive value of 3%. But remember, we want to work out if there are any other warning features here. And those warning features, weight loss, malignant rectal exam, hematuria. So we do a rectal exam. His rectal exam, in fact, shows a hard, craggy prostate. How does this affect his positive predictive value? Well, let's look at it. You combine it with nocturia, 15% positive predictive value. Combine it with hesitancy, 10%. So now we've got a very different ball game. This patient may well have prostate cancer and urgent referral will be recommended. You run a PSA. His PSA is 10. You repeat it, it's 12. Okay? You make a referral. Let's talk about case number 2 now. Case number 2 is Ted. Ted's a 75-year-old retired farmer. He hasn't come in by his own accord. He's been sent in by his wife, as many old blokes are. And he's been losing weight and he's been complaining of aches and pains, especially in his back. He hasn't been sleeping well, partly because he has to get up several times a night to pass urine. He rarely comes to see you and he denies any other symptoms. So what range of possible diagnoses would you have to consider here? So it's back pain, it's weight loss, and it's lower tract symptoms. So in this situation, we'd be worried about malignancy. If you refer back to the tool, we're talking about weight loss and nocturia. And so we find that that may well represent prostate cancer. The positive predictive value of the combination there is 12%. So there's that. There's a possibility of prostate cancer. What else? Well, it could be other malignancies that have gone to the back, I guess, such as melanoma, thyroid cancer, bladder cancer, many other cancers. So malignancy in the back would be a possibility. There would be other things like retroperitoneal pathologies, I suppose, pancreatitis, pancreatic cancer, peptic ulcer disease. Each can produce back pain, anorexia, weight loss, and so on. So the range of potential diagnoses here is broad. But by referring to the tool, we can see that prostate cancer has already got to be up there in terms of the potential diagnoses. So you do an exam. On exam, you find that the bladder is palpable to the midpoint between the pubic symphysis and the umbilicus. So that means he's got 300, 400 mils in his bladder, and he has an enlarged prostate, but there are no hard or irregular areas. What investigations would you order? Well, your investigations will be tailored according to those potential diagnoses, and they would have to include a PSA and a urine culture. We'll run a panel of labs looking at liver function and so on, and you'd probably want to do some imaging, and we'll come back to that. So the results come back as this. So the EGFR is 55, that's down a bit. Most of his labs are fine. His PSA is 16, okay? But his urine test shows E. coli. What are we going to do with that? The PSA is 16 and he's got a UTI. Well, urinary tract infection can significantly change PSA. So what we need to do in this situation is treat the urinary tract infection sufficiently and then repeat the PSA. So you do that. You put him on antibiotics for a week and you repeat the PSA. But we're also worried about the EGFR here, aren't we? So I would probably do some imaging. There's a number of possibilities you can do for imaging. My own personal preference would be looking at a CT abdo-pelvis with IV contrast, because through that we can look at the bone windows, we can check the bone for metastatic deposits, we can look for retroperitoneal pathologies and intra-abdominal malignancy. And also from the point of view of urologist, it can show me whether there's any hydrouronephrosis to suggest obstructive uropathy in relation to that reduced EGFR. So at this point we can look at some questions. And while the questions are coming up, just to summarise today, prostate cancer is the most common cancer diagnosed in Australian men. The 5-year survival rate is high, but unfortunately prostate cancer really only comes home to roost in 10 to 15 years from diagnosis. Today we've talked about the Finding Cancer Early tool, which is a useful guideline for GPs trying to work out the likelihood of a patient having underlying prostate cancer based on single or paired clinical features. We've talked about the Prostate Cancer Foundation, Cancer Council Australia clinical guidelines to guide PSA screening the asymptomatic men. And we've talked about some care pathways to provide efficient and safe care for patients for whom there is PSA concern or prostate cancer concern. DRE does impact on PSA levels, but only by a small amount. So probably about 0.2, 0.4 nanograms per mil max, to the point where I don't tend to worry about it. So I will just go ahead and do a PSA after a rectal exam because the impact is quite marginal on your PSA measurement. Perhaps while we wait for a question, I'll just have a little bit of a chat about PSA. So PSA is actually a normal epithelial cell production from the prostate. It's a human kallikrein enzyme, in fact. It's involved in fertility. It is used to lyse cervical mucus, it liquefies semen, so therefore involved in fertility. So because it is produced normally by the prostate, as the prostate enlarges with time, we would expect to see the PSA rise with time. And that was the basis for the age-related reference range for PSA. We've been talking already about how urinary tract infection affects PSA, and indeed it does. Other things like urinary retention, instrumentation, bike riding, ejaculation, all of these things can affect PSA to small amounts. If you've got a case where the PSA is just a little marginal, then make sure the patient is abstinent of ejaculation for about 3 days and they're not a crazy bike rider, because it will actually affect the PSA to a small amount, up to about 0.8. Again, urinary tract infection, be careful to exclude and treat that if needed. The half-life for PSA is about 2.2 days, so it does take a bit of time for the PSA to return to baseline after you've had an event that raises the PSA. So if the PSA is above median for age, I think the key there will be to monitor it serially over time, and if there are no other symptoms and the PSA is rising at a concerning rate, then the patient may require further evaluation. Now, the concept of using PSA kinetics to screen for prostate cancer remains a little controversial. Its role is definitely established in the patient who has a negative initial screen and is then re-referred. But for the initial referral, it's a bit controversial. The figures come out of two major studies, the Baltimore longitudinal study and the Malmo prevention study. From those studies, we'd say that if the PSA is less than, say, 3.0, then a PSA rise of more than 0.375 nanograms per mil per year may reflect prostate cancer as the underlying reason, as opposed to just BPH and prostate enlargement. If the PSA is more than 3, then a rise of more than 0.75 nanograms per mil per year would be a concern. But of course, the PSA more than 3 is, by the current definition, a concern anyway. So, a great question. So, free to total ratio is important. Its role is probably in the patients who have PSA less than 3, but who are at high risk of underlying prostate cancer. So in those situations, for example, a patient who has a PSA between 2 and 3, but a free to total ratio of less than 25%, referral should be considered. And in fact, that's actually in the guidelines as well. I would treat the urinary tract infection, prove that it's gone, and then repeat the PSA somewhere between 3 and 4 weeks after the initial PSA. Yes, so that's a great question. Well, as you know, the MRI will be precluded because of the pacemaker. But when it comes to biopsy, I think it'll be a case of talking to the patient about what it is the reason for their concern about the biopsy. Is it infection? Is it retention? Is it hematuria? What is the issue? Is it discomfort? We have ways around all of those things. So I would start with that particular point, saying, because biopsy really is the next step for that patient. There is some interest in CT, but I must say this is very, very early days. But it's interesting to see when patients are having CT for other reasons, how often there will be contrast enhancement in an area of a prostate cancer. But this is, I must emphasise, experimental. This patient needs a biopsy, and that can be achieved. His fears can be addressed, and we can achieve that.